Welcome everyone to today's webinar, Detect the Undetected, Addressing Drug Diversion in 2021. On behalf of Becker's Healthcare, thank you for joining us today. Before we begin, I'm going to walk through a few quick housekeeping instructions. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. We will also have a series of poll questions during today's webinar. You can submit the answer that best applies to you directly on your screen. Thank you in advance for your participation. If at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We are here to help. With that, I am pleased to welcome today's speakers. Tyler Carlson is a Senior Sales Engineer at Fair Warning. Kara Earle is a Product Manager at Fair Warning. And Laura Grimes is Director of Pharmacy at Memorial Health System. Tyler, Kara, and Laura, thank you for being here with us today. Tyler, I'll now turn the floor over to you.
Thank you so much. We really appreciate everyone's attendance here today. I'm going to go ahead and advance to kind of an agenda that we have on our schedule for today. Lots of exciting topics. We're going to kind of start off with really addressing some organizational gaps and some different cultural pieces that come along with the topic of diversion. Hopefully give you some tips on maybe how you can overcome these within your own organizations. We're going to talk about diversion red flags. So we're really going to take a deep dive into what are some of the typical actions and methods that we see across our customer base for diverters. We're going to go into really the lasting impact of diversion. So really the reason that we're all here today, spending our time to talk about this topic. We're going to have some discussion topics as well where we can talk about, how are you identifying incidents of diversion today, and maybe how can we more effectively identify diversion incidents in the future. And then we're going to talk about really automated versus manual monitoring. So how can Fair Warning help? How can other tools help to automate some of these processes? Historically, this has been really a process that has been largely manual. So how can we automate those processes and make them much easier for you as an organization? Now, really jumping right into the content, the first piece that we want to cover are some organizational gaps and then some kind of culture pieces. And we hear many times with customers that are onboarding, customers that we talk to that internally, there's oftentimes a cultural challenge when it comes to really establishing a fully fledged diversion monitoring program. Oftentimes, there's an internal belief of, we don't have that problem here. It's not as big of a problem as some may think. And obviously, we're in the business of detecting diversion. We know it's a huge challenge, it's a huge problem. So, I'd like to engage Kara or Laura. Have you, in your experience, run across this cultural challenge? Have either of you kind of been in those shoes of having an organization say, maybe we don't have this problem. Maybe this isn't something we need to monitor.
Yeah, thanks, Tyler. And
Laura.
Kara speaking. Oh, sorry, Laura, did you want to go ahead first?
Sure, I'll just go real quick. Just speaking from my healthcare system, I was newer to the organization a couple of years ago, and when I first started asking that question, walking into the system, if there was an issue, pretty much everybody shook their heads and just said, no, we haven't heard of anything. We don't really have any reports going on. I think we're good to go here. For a 200-bed hospital with EDs and the outpatient, I was a little concerned with that, but yeah, definitely from my side, I've walked into that.
Yeah, and Laura, we'll talk more later about really the kind of how drug diversion monitoring has progressed through the years. And so I think that'll be a great topic that we can bring back up as we get to that section as well. And Kara, what are your thoughts on this?
Yeah, we've definitely seen this, Tyler, with a lot of our customers or organizations that we've talked to about drug diversion monitoring, where it kind of varies depending on what level of the organization you're speaking to. Generally, if you're talking to somebody in pharmacy or nursing who's out on the floor, they know it's probably happening. They may not be catching it or looking for it in the best way, but they know this is something that happens at every organization at one point or another. It's when you get kind of higher up that you see some of that denial come into play. You get into, administration or executive level, and, they're not as involved in the day-to-day, and so they may think, well, I haven't heard anything, so no, I think we're probably fine here. And we've seen that's really just not the case, and every organization should be proactively looking for diversion, whether or not, you're aware of any current incidents that have occurred at your particular hospital.
Absolutely. It makes complete sense. And I think, the good news is we'll kind of go through and give some tips on how we can overcome that challenge. But really the next one that I think we hear probably, and Carrie, you hear this frequently, I know, and talking to you prior to this, is that organizations may be thinking that kind of manual matching is enough. That, if we're doing matching of dispensing cabinet activity, versus what's happening in our EMR or our EHR, just doing that matching is enough. Kara, what are your thoughts on that? I know you're passionate about this.
Yeah, definitely, Tyler. I think this really stems from this is sort of what has always been done. This was the way to look for diversion previously. It was, you run reports out of the dispensing system, you run reports out of the administration, and you compare. And if somebody's diverting, you'll catch them that way. And we know that really just isn't the case anymore. People who are diverting medications are very careful. And so you may not catch something this way. You really have to kind of think outside the box, know that the diverters know what you're looking for, and really identify other ways that you might be able to identify diversion before you get to the point of you haven't caught something and now somebody's overdosed in a bathroom, which is what nobody wants, but what we've seen all too frequently.
Absolutely. And that kind of brings me to the last piece here that we want to cover kind of right out of the gate here is, I don't like the term cover-ups, but potentially, turning a blind eye where we're saying, hey, if the math matches, we're good here. We certainly know at Fair Warning that the math oftentimes does match and the diverter is still diverting. And so, Laura, I'd love to kind of get your input on this piece. Have you had experience in the past where, maybe the math does add up, but we still have something that's going on here that needs more than just math to uncover?
Oh, definitely. Yes. I've had a couple instances where everything looked great from running reports and, just from the pharmacy standpoint, from nursing standpoint, looked great. But then you really started to have to look at some, particular behaviors that somebody may have had that we started questioning. Why were they getting into some cabinets more than others? And just some questions, but yet the math always added up. So definitely.
Absolutely. And we'll talk more about red flags here in a few slides. And that's, kind of one of the fun pieces to cover is what are those red flags. But one of the things that I know, Kara, you've mentioned is kind of correlation. So it's not just about math. It's about correlating user behaviors or user activities across multiple kind of segments of actions. So if we have one person who has, an unusually high access, that single access may not mean a whole lot, but if they're also displaying, 4, 5, 6, 7 other types of behaviors that can be associated with diversion, that's maybe a good indicator that there's someone we need to look at.
Yeah, absolutely, Tyler. We see in day-to-day monitoring, we see a lot of what we'll call sloppy practice, right? We see a lot of nurses, pharmacy techs, anesthesiologists, anybody really, who will show up on a report, generate an alert, when it's really just sloppy practice. It's just that they're not following the exact policies and procedures. They're not documenting appropriately. And we obviously want to catch those things. We want to see those incidents and go and correct that behavior. But with diverters, what we often find is they really show up across many different categories, all different red flags, and some that can be caught in the data and some that are more behavioral and really have to be seen. And I know we'll go into that a little bit on those red flag slides, but you really need to look at the user's whole behavior across multiple audit sources, across departments, across a whole health system. If you have float nurses, travel nurses moving around, you really need all of that user's activity to be able to identify those true diverters.
And so what I take away from that, Kara, is the more data, the better, and the more correlations that we can do across sources, the better.
Always. Absolutely.
Perfect. So next here is a quick poll. So we're going to kind of pivot a little bit here and go into a poll. These are always fun. This one is kind of an interesting question here. So we'd love for kind of the audience to interact here with our poll. And so the question really is an estimated blank percentage of diverted controlled substances within health systems goes undetected. So what percentage of diverted controlled substances today does not get detected over time? And we'll give you a hint. It's between 5% and 95%. So go ahead and we'll take some time to answer our poll here. Let's give it a couple more seconds here. All right, so I'm going to go ahead and advance and see if we can get some results here. All right, so the majority of our audience got it correct. So we have 48.5% answered 95%, and that's the answer. So I know that oftentimes people say, that's crazy, how can it be 95%? And one of the things that we've come across at Fair Warning when we do an initial deployment is that we find diverters who have been diverting for years, months or years. They've been going undetected for an incredibly long period of time. And I really think that's what contributes to this large percentage of undetected medications being diverted. It's not necessarily the quantity of diverters themselves. It's oftentimes the length of time that they go undetected. Again, we've talked already about, the math adds up oftentimes. We've talked about manual matching not being enough. And so these individuals, they kind of know the way around the system. They know that the manual matching is happening. They know that there's math being done. And so that really contributes to that large number. Laura, I'd like to ask you, are you surprised by this? Is this something that kind of jumps out as you as surprising, or with your experience, does this seem in line to you?
I mean, at first view, it seems high. But I think from what I have seen, at my facility now, not as much, but at previous facilities, when you really start digging into it, you are oftentimes surprised by what could be found. So really, at the end of the day, I guess I shouldn't be surprised by that number.
Absolutely. It makes complete sense. And I think it's a testament to kind of the stage that we're in with diversion monitoring. We're rapidly discovering new things. We're learning so much more, and that's why it's great to have webinars like we're all on here today, is to learn more and become more effective. But yeah, definitely a shocking statistic, I think, to many people. All right, so now we're going to jump into kind of one of the biggest topics that we have in today's webinar, and that's red flags. So I'd love to get, we have our experts in Kara and Laura, and I'd love to get kind of some ideas from your experience on what are some red flags that we can either be monitoring for in our proactive monitoring programs, or we can be looking for. And I have a slide next that's going to cover kind of some of the top red flags that we monitor for at fair warning. But I'd like to turn it over, and Kara, I'll ask you to get your input first. What are some of the most common red flags before we kind of show the ones that we monitor for? From your experience, what would you say are some of the top things that kind of denote these actions?
So I think there are a lot of sort of obvious things that, like you said, we're going to cover on the next slide that people know to look for. But at the same time, diverters are smart. They know to look for those things now as well. They know what you're looking for. So some of the most common things we've seen come up recently that have really kind of, directed us to look at a certain person, or we've, when we've looked into someone, found some consistencies. A lot of traditional diversion monitoring has focused on controlled substances. And what we see is that users who are diverting controlled substances are also diverting a lot of non-controlled substances. And that's something that goes overlooked by a lot of systems that can really kind of point you in the right direction. If you have somebody who's dispensing massive quantities of Benadryl, that's a huge red flag that people don't think about. But all those additional medications that, are related, if you will, to an opioid addiction, those medications that help with the symptoms or help with the side effects, those should be monitored pretty heavily as well. And then Laura can probably talk a lot more about this, but there are a lot of things you won't see in data. There are plenty of things you can monitor through the data, but there are definitely some red flags and some behavioral changes that organizations should be looking for that really are going to be your first indication a lot of times that somebody might have some kind of issue going on.
Yeah, definitely. I will say too, Kara, just from your first point about the other medications, I have been somewhere before where we've had somebody who has dispensed a lot of Tylenol 500, and really didn't think too much about it until we realized that the integrity of Percocet packaging had been messed with, basically, and had been replaced with Tylenol tablets because they actually look the same. So obviously there's an example where numbers matched up, but when you looked into it, we started then looking at Tylenol dispenses and found how large that problem was. So definitely a good example with those other medications. And yes, of course, just things that just aren't in the data, just, when you're matching those, from a dispense to an administration, looking at how people interact with each other, as far as witnessing, there's just so much more out there than just what the data shows.
Absolutely, and I think you both bring up such a good point. I kind of want to drive it home. It's non-controlled substances. There's a lot of organizations out there that I know that are only monitoring for controlled substances. There's a lot of systems and tools and applications that only look at controlled substances, and you're missing a lot. There's a lot that we can find by monitoring, all medications. And I know that historically it's been, hey, let's look at a narrow set because we don't have automation. And if we look at everything, it's going to take us, it's going to take 4 people with full-time jobs doing it. But the good news is today we have systems like Fair Warning that can take all of that into consideration and monitor all substances automatically. Now, I'm going to go ahead and advance here to some of the more, again, common red flags that we have come across at Fair Warning during our monitoring. Some really common use cases that we monitor kind of day in and day out. And oftentimes this is where we start with customers. What are we going to look at first? Well, let's look at these kind of broader behaviors. Let's look at wasting behaviors. Let's look at inventory discrepancies. Who has behavioral changes? So with Fair Warning, we can trend behavior over time. Who is, the day before they take a day off, every single time they dispense double the quantity of medication. And let's correlate that back over every single day off they took. If you have someone who's dispensing double the quantity every time the day before they take a day off, pretty good indication that that person has maybe a substance abuse problem, and they need to stock up for that day off. So there's a lot of different red flags here. Kara, any that you would point out as kind of especially important or that tend to have kind of a higher hit rate as far as, finding behaviors that are really, red flags?
Yeah, absolutely. So I think some of the big trends we've seen lately are things like some of the patient indicators, looking at patient pain scores. Even if you don't have pain scores available in your tracking system in your data, you can look at trend how users are dispensing medications for a specific patient compared to other shifts, for example. Does it make sense, or is it normal that a patient would need twice as many doses of morphine when one nurse is working than when anybody else works? Probably not. And then also, again, correlating those non-controlled substances. One of the things that we've seen across several customers recently is substitution of medications, where the user is dispensing the pain medication for the patient, as well as a non-controlled substance that, if you're in the hospital and you're able to check, I bet they look a lot alike. I bet that tablet of Percocet looks a lot like that Tylenol or that Claritin, that loratadine, where, they can take that to the patient instead and keep the pain medication for themselves. So that's been a big trend that we've seen with customers, particularly in the last few months, Tyler.
Interesting. Laura, anything you'd add on that piece?
I think from my side, really, it's just starting to see an excessive use of certain machines compared to other people within their peer groups. That's, at least from my experience this past couple of years, has been where we've really targeted when we do think that there is an issue going on. So that's a good indicator, at least from my side.
Certainly. And I know that we have, drug diversion on all these slides, and we're talking about diversion, but, one of the things that I also want to draw attention to are policies. Obviously your organizations have policies in place for, how long you can hold medication before wasting. Can you bulk waste? Can you dispense a medication and hand it off to somebody else? So Kara, are we seeing lots of policy violations as well? Are we helping customers with that, or is it simply kind of diversion?
Oh, absolutely. Plenty of policy issues. And, one thing that's always still a little bit surprising to me when we have new customers who come on board is they may think, particularly the pharmacy leadership, they think that their nursing staff is following certain policies and they're doing certain things. And then they find when we start monitoring that that's not necessarily the case. And it's, it's nothing negative about nursing, but they get busy. They look for, especially now when, we've got so many COVID cases and they're overloaded with patients, they look for the fastest, easiest way to do things so that they can get back to patient care, which is great. But at the same time, we really try to focus on some of those policy issues and support education and counseling and retraining of whole departments sometimes, because we know that when everyone is following your policies, everyone is following your best practices, the people who are diverting are so much easier to find. They will pop up so much faster than if everybody's just violating the same policies and has the same sloppy practices.
Yeah, and Laura, I'd like to ask you, and I know I'm putting you on the spot a little bit here, but as a fair warning customer, were there any pieces that were kind of eye-opening to you when you implemented this program from maybe a policy perspective?
Oh, definitely. I'll be the first one to admit, when I started working with Kara, that example of that, the excessive time between dispensing and administration, it was eye-opening from my perspective. Mm-hmm. We are finding 6-8 hours in between. Sometimes, maybe the next shift something was taken care of. Mm-hmm. And when we went to nursing leadership to discuss that policy, they pretty much, they weren't aware of a set time. So it was something we all had to kind of take a step back and really determine what should be best practice and how do we start educating, our nurses and our staff and explain to them that, this does open people up for diversion. We're not targeting you necessarily for diversion because you have that Norco out for 6 hours, but here's the reason why we need to focus on it and really get that education and really set good policies behind, what that best practice should look like.
Absolutely, and I think that's such a super important point. And really, when we get that policy adherence down, it makes it easier for us to find diverters. because when you have other individuals who are practicing against policy or in a sloppy manner, it makes the diverters, it's easier for them to kind of hide, and kind of hide behind others who have sloppy practice or who are just refusing to adhere to policy. So when we clean all that up, it makes the diversion monitoring even that much more effective, which is kind of a bonus, definitely a benefit. All right, and so we're going to pivot a little bit here now, and I want to talk a little bit about, quite frankly, why we're here, why we've all invested the time to kind of be here, why we do this, why we at Fair Warning decided to build a drug diversion monitoring platform that did so much more than what was possible in the past. And quite frankly, it's the lasting impacts of diversion. And I know that, considering the audience we have today, we have a lot of individuals from pharmacy, we have a lot of law enforcement individuals on this call today. And so I know you're familiar with these lasting impacts, but the ones that really kind of hit home for us and kind of drive us to do what we do is really effects on patient care, effects on the care provider, and then the one that oftentimes goes either minimized or unnoticed is the effects on the diverter themselves. Obviously, they're going to be dealing with a lot. The vast majority of these diverters have a substance abuse problem. They're not typically doing this for financial gain. Some are, but most of them, they have a problem. And so, we really like to take this in consideration and kind of drive this home is that, this is why we're here. This is why we do this. And I'd like to kind of loop in Kara, Laura. Do any of these stand out to you as, really top of mind when it comes to why we're doing this comprehensive diversion monitoring?
Yeah, well, for me, Tyler, it always comes back to patient safety. And so the effects on patient care to me are the primary concern, right? We want to make sure, as you mentioned, the vast majority of users who are diverting are addicted. They're diverting for personal use. And they're not only taking the medication when they're at home and at nights and on the weekend. If they have an addiction to a pain medication, they're taking it all day, throughout the day, while they're at the hospital. And so that means that you have an impaired provider caring for your patients. And, as we've mentioned in the beginning, they might be okay. They might be able to, be functional and be, not causing patient safety errors. But over time, if they're not caught, we see more and more after a year and a half, as their tolerance starts to build and they start to take higher and higher doses of medication, that's when they really start to make some of those errors that will affect your patients. So for me, that's always the top concern. I'm sure Laura will say the same. But anything different, Laura, that you've seen or that you guys have been primarily concerned about?
So, of course, definitely the effects on patient care. We can't have that happen to our patients. We can't have them being treated by somebody who is impaired, because we know kind of that route that diverter, that the person that is impaired, they're going to take. It's going to get more and more and become more dangerous to our patients. But at the same time, I've come across a couple of situations where I've really had to think more about the effects on the diverter themselves. We think about patient care. We think about when we report things, all the paperwork, all the DEA things, all the Board of Pharmacy. But at the end of the day, if we don't do our job, for looking at the diverters, we could have a diverter that, wrecks on the way home because of impairment, maybe overdoses at home because they're taking more and more medications to basically, get because of the addiction that they have. And, I have seen instances where, as sad as it was, we have to report it, but we knew ultimately, even with the criminal record, even with some of, the police involvement, it was hopefully going to help that diverter turn their life around.
And that's such a good point, Laura, and it brings up another kind of topic that's along the same lines, and it's if you don't report these, if you don't kind of get involved and ensure that these individuals get help, they're just going to go somewhere else. We've had customers on board, and we've found people diverting who were diverting from basically day one. We look back over their historical access, and their access from the day they started at that organization was anomalous. And what that tells us is that they were at another organization diverting. They either got caught or they, quit for one reason or another. They go next door to the next organization and start doing the exact same thing again. And had that organization that originally detected them, gone through the proper procedure to get that individual help, we may have been able to save the next organization from having that person, cause issues there. So definitely an important piece to keep in mind. All right, and so this is the kind of discussion question, Laura, that I alluded to earlier, that you kind of mentioned and touched on a little bit, but I want to really kind of dive in a little bit deeper on this. And it's really, how has drug diversion monitoring changed over time? And so I know it has, so we'll go ahead and assume that. So, Laura, could you talk through a little bit of kind of a timeline maybe of how it used to be versus how it is today as far as diversion monitoring?
Sure, definitely. So I guess I'll go back about 2 years. That's kind of when I came on board, with our system. When I came there, diversion was a topic that we didn't really have any kind of diversion program, no kind of diversion committee, really nothing in place. And when we started looking at it, we did not even have a lot of policies in place for cleaning up, discrepancies at the automated dispensing cabinet. We were basically almost at square one, especially when you look at it from the pharmacy standpoint. Now, luckily, our nurses, the nurse managers, they had been doing chart audits. And they still do that today, where they basically take, 10 random charts a month, and they look at pain scales, they look at, dispensing from the cabinet, and they look to make sure that everything is being administered, by looking in the EMR. So that's kind of where we started. And really to catch anything was by accident. It was looking at, billing that maybe maybe just didn't, look right. It was somebody called and said, I don't know, this person, something's just not right. But even in all those instances, everything was just so time-consuming to look into. So very quickly, we knew that, as more issues were popping up, we needed something to help us. So about a year ago is when, we contacted Fair Warning, looked at what, could help us. And it really, honestly, it's changed the way that we look at drug diversion. It finally, it gave me a platform to take to administration to say, hey, we have this ability to monitor closely, but this is something that we all need to work all together on to really accomplish something, a good change for the facility. So, like my example earlier, we're finding policies that maybe were not our best practice or hadn't even been addressed, like the time between dispensing to wasting. So as soon as we brought this on, we had a little bit deeper dive of basically what could be seen with the monitoring system. We were able to take more of those policies to administration, the PNT, to nursing leadership, and really start affecting change. We've continued that path, and I'll just say at this point now, we're hoping to start a more robust diversion committee that just kind of takes this a little bit further rather than just phone calls and emails and discussing, in between the departments. We're kind of, I guess, in that middle phase. We've got a lot more ground to do, but we have moved so far just within the year we've done this.
Absolutely, and huge kudos to you, Laura, as well, for really taking a program from its kind of infancy into now having an incredibly advanced program, and it sounds like about 2 years. That's fantastic to hear that you were able to make that happen. But another point is, as we go through these topics, this isn't something that happens overnight. And I think you brought up a good point. This is something that, it's gradual change. And so for those of you that are kind of in the process of establishing a diversion committee, establishing a diversion monitoring program, definitely understand that we know it's a long process, but we're certainly here to help. All right, and so we will go ahead and advance. So we do have another poll question here. So I want to kind of ask, for those of you, and I know we have a lot of law enforcement on the call today, so for you individuals, it probably doesn't apply as much, but for our health systems or pharmacies that are on, how are you identifying potential incidents of diversion today? We have a couple different options here. So are you doing this completely manual or nothing? Do you have some kind of partial automation or kind of rudimentary tool? Do you have a fully automated tool with AI like Fair Warning, or are you doing something else? So I'd love to give the audience some time here to kind of answer this question. I'm definitely interested to see the percentages that we have for this particular poll here. Kara, any guesses on which one's going to come in first?
Tyler, I think partial automation will probably be in the lead. I know the more advanced analytics tools are still relatively new. They haven't been around for more than 4 or 5 years. So I know a lot of customers we talk to are still doing everything manually, or they maybe have a static reporting system they're using. So I expect to see probably split between those two for the most part.
Perfect. I'm leaning a little more towards the manual side, but let's go ahead and see what we have.
Yeah.
All right, Kara, you hit it. So 50, yeah, you win a to be determined prize. So we have 54.9% that have some type of partial automation in place. So again, we run into that quite frequently. About 18% have manual processes or completely manual processes. So I know we feel your pain there. We've heard a lot from that group. Great news is 15, almost 16% have an automated system with AI. So that's a higher percentage than we've seen in the past when we've done these polls. So it sounds like that we have a higher adoption rate, which is fantastic because that obviously helps everyone. And then 11% there in kind of the other category. So definitely some good information here. All right, so another discussion question here, and this is more so centered around resources. So I know that, Kara, you are an expert on drug diversion. Laura, I know you are as well, and you've been involved, again, in the program for some time. So I'd like to ask, and Kara, I'll start with you, other than peers or, other than kind of the standard word of mouth, where do you go or who do you look to for drug diversion kind of assistance?
Yeah, it's a great question, Tyler, and one we get all the time. Where do you go if you're just starting out? Who do you talk to? Who do you look to for help? And there are a number of professional organizations out there that are available. A big one for everyone, I'm sure, on this call is ASHP. ASHP produces guidelines on all different topics related to hospital pharmacy, but they're actually getting ready to revise their diversion policies towards the end of this year, so we're excited to see that come out. Joint Commission also has some interesting standards that apply to drug diversion that are really expanding. Recently, they're looking more at medication management, so we've seen those standards change and increase over the past couple of years. And then really, for me, there are two primary professional organizations for drug diversion monitoring specifically. NADI, the National Association of Drug Diversion Investigators, and IHFDA is the International Health Facility Diversion Association. So those two organizations are really very specific to drug diversion investigation and offer great training and opportunities for any type of investigator or user, anybody involved in drug diversion, really.
Yeah, and as a member, I can say those are definitely fantastic organizations. Laura, any that you would add? I know Kara covered pretty much all that I could think of. Any that you would add?
No, nothing more to add. Just to kind of reiterate two of them that she mentioned, both ASHP and the Joint Commission. Really, Joint Commission just in terms of any accrediting agency. So obviously, from a pharmacy standpoint, I'm always going to be concerned about diversion. But when I want to take something to my administration, I need more than just, my beliefs and my concerns. So when I can take ASHP national guidelines, when I can take, HFAP, Joint Commission accreditation standards and say, this is why we have to do it, that just gives me a little bit more, of a starting ground with the C-suite and really get that discussion going. So definitely those two there.
Perfect. Thank you, Laura. All right, we have another poll. So we really want to ask a little bit about where this kind of responsibility lives. And so when it comes to maintaining a drug diversion kind of monitoring program, we'd like to hear from you. Where does it live? Who owns it? Is it human resources? Is it pharmacy? Is it some sort of cross-functional team? Or in your organization, is it something else? So give some time here to answer this particular question here. Laura, any guesses from you as to where this one's going to land as far as first place?
Yeah, I would almost say pharmacy may be a leading one, just because that's it's a medication. It kind of seems to always land in the pharmacy's realm.
Yep, totally understandable. That was going to be my guess too, but let's take a look and see here. Wow, so cross-functional team is number one. So Laura, you and I don't get the prize, but yeah, interesting for sure. And I think that's good. I think that having a cross-functional team is a good thing. having more people involved instead of having it just fall on pharmacy. Obviously, we still have a very high percentage here that answered pharmacy, but having a cross-functional team, I think, is really important because it's not just about this living in one area or kind of one person's responsibility for sure. Kara, any thoughts on these statistics from your perspective?
Yeah, it's actually a little bit surprising, Tyler. I mean, it's a good thing, like you said. We always kind of stress with our customers. I know the prevailing guidance these days is that it really should be a cross-functional team, that you should have buy-in from, your nursing staff, your medical staff, your anesthesiologists, really across the board. But what we hear from a lot of customers is that it's always been a pharmacy issue. So maybe this is a sign that that's changing a little bit for the better.
Absolutely. And Laura, it sounds like your organization, Memorial, you fall into the cross-functional team category, correct?
We do now, yes. Originally, like I said, it was considered a medication issue, so it fell within pharmacy's realm. It was, we were helping to do the DEA reporting, so this was a huge focus that we had as we were kind of bringing this diversion program up and running, and bringing human resources into it as well. It shouldn't be just your, director of pharmacy that is, talking to the possible diverter and trying to get information and then deciding if they should be terminated or not. That really should not be pharmacy's realm. So I'm very excited to see that we've got a higher amount of the cross-functional team. So that, yeah, I'm excited about that. I'm glad we're moving that direction.
Absolutely. Definitely. Good news here for sure. All right, and I'm going to go ahead and cover this last slide. I'm going to breeze over this pretty quickly. I want to make sure we have plenty of time for kind of Q&A at the end here. But for those of you that are wondering, we've talked about diversion, we talked about fair warning specifically, and for those of you that are wondering, well, what is included with fair warning? What does fair warning actually do? Well, obviously, we are a software platform, but we're much more than just a software vendor or software platform. Each of the tiles that you see here on your screen are what we include for our diversion customers. So the first thing that I always like to cover is the dedicated expert. So at Fair Warning, we really have a truly elite team of individuals that we partner with our customers to kind of help them along the way. Kara's one of those experts, and I know Laura's had the pleasure of working with Kara. We have a whole team of individuals like Kara who have experience in this realm, whether it's narcotics detectives, whether it's just PharmDs, whether it's people like Kara who have done diversion investigation from a state or regulatory perspective. So having that dedicated expert is huge. At Fair Warning, we're never going to just have our customers kind of go at this alone. We definitely always have that expertise and kind of guidance along the way. Another piece that I want to cover is the investigation module. So built into Fair Warning is a fully comprehensive investigation module that allows you to document any instances of diversion that we do find. So if we find diversion, if we alert on it and we find it, the next step is, hey, we got to document this. We got to make sure that we're complying and that we have everything documented centrally. And our investigation module is a great place to keep that documentation. Also a great place to keep documentation of even just policy violations. Do we have someone who is consistently breaking our policies? And that can all be documented in Fair Warning as well. Now, at the bottom of the screen, you'll see kind of the bread and butter of Fair Warning. That's our proactive behavioral analytics and our AI or artificial intelligence applied analytics. So we take a two-pronged approach to detecting incidents within a healthcare system or a healthcare organization. And this two-pronged approach is very effective. Like I mentioned, we've oftentimes onboarded customers, and we found people who have been diverting undetected for a very long period of time. And so this two-pronged approach allows us to look for behaviors that we know are oftentimes associated with diversion, all those red flags that we talked about earlier. But then we also acknowledge that there's some behaviors that are occurring that might not stand out to us on a standard deviation report. They might not stand out to us in a behavioral analytic. And so we can apply AI to look for those behaviors that are maybe more subtle, more emerging patterns. We can also focus this on early detection. So what is the profile of someone who is just starting to go down the path of diversion? How can we detect that individual very early on? Then lastly here is compliance and governance reporting. So obviously at Fair Warning, we always supply our customers with kind of a constant health check on how effective your program is so that you can always evidence to a diversion committee, to a steering committee, to a board, how effective you are with your diversion monitoring program. All right, and so from here, we have our Q&A, and I can already see that there's more questions that have come in than we can possibly answer, so there'll definitely be some follow-up, but I want to kind of turn it over to the Q&A session now.
Thank you, Tyler, Kara, and Laura for that great presentation. We will now begin today's question and answer session, and we also have Dan Borgasano, Vice President of Imprivata, joining us for today's Q&A session. So you can submit any questions you have by typing them into the Q&A chat box on your webinar console. And like Tyler said, we've already had a lot of questions come in, so we'll go ahead and get started with the first one. And this question is, this audience member wants to know, do you address propofol in your program, and if so, in what way?
Yeah, and I'll go ahead and
yes,
start
propofol.
off and take
Kara.
that one. Yeah, and I saw we did have a couple questions come in about that are pretty similar about propofol and other non-controlled medications, and the answer is yes. We absolutely do. A lot of those medications they're kind of borderline right now, right? They're controlled on some state levels, but not on a federal level, or they're medications that we know are kind of the next drug of choice for diverters. So absolutely, 100%. As we mentioned, Fair Warning monitors all medications, not just controlled substances. So we have found, actually, without going into too much detail, have an open investigation with the customer as we speak, with a user diverting gabapentin. So that's absolutely something that we're looking at and we're tracking very closely.
And one thing that I'll add on that is we can actually create a suite of what we call supporting medications or additional medications where it's kind of a list of medications like propofol that we want to also pay close attention to, but they're not going to show up in a controlled substance report. So yeah, definitely something we can do there.
Thank you both so much. And we'll go ahead and move on to the next question now. And this person is wanting to know what time frame between dispense and waste or dispense and administration is a best practice or reasonable?
And Laura, do you want
I know
to
you
go
guys
ahead and
probably
take
have...
that one? Yeah.
Yeah, I can speak to that. So that's definitely, we had to define that, for our own facility. And, pharmacies always said that it should just be done immediately. Obviously, that doesn't happen in real time. So what we kind of narrowed down for right now, we set a 2-hour limit. I think that's honestly a little bit too much. But for right now, we had to set a time period. We'll be moving to, we would like to do more of like a 90-minute max, but we need to get nursing on board with really talking to the patients first, really seeing if they need some of those medications, some of those PRN narcotics before they even pull the med. Because honestly, that's where we run into a lot of the issues. They think they're going to need Norco, they go in there, the patient says, no, I don't want it, and they get busy. So there's some behavioral things that we need to address. But for right now, we settled at 2 hours.
Yeah, and I'll add to that a little bit as well, Laura. We've seen a lot of variation across our customers, and there's not really a good standard across, every state or every agency on what that number should be. But I think the generally accepted best practice for most healthcare systems is that, in an ideal world, waste would occur at the time of dispense. You have that integrated waste option with your dispensing systems where if you have a medication and you know that the, cabinet's going to dispense more than the patient's dose, it should be wasted at that time before you ever leave the med room. We know that's not possible in every situation, right? There are always going to be times when waste has to be completed later. And so for most of our customers, really the goal is to get to about 30 minutes to an hour. And so that's where, we see a lot of our customers ending up. As Laura mentioned, sometimes we have to start a little bit higher for our monitoring. We've had customers start as high as 12 hours. Really, they have such an issue that they start with, okay, let's just pick out those incidents where waste wasn't completed at all. Somebody went home and came back the next day and did it then. But the goal is to bring that down over time and really get everybody as close to the time of dispense or administration as possible. And I'll kind of tie that into, sorry, go ahead.
No, go ahead. I was just going to move on to the next question, but don't want to cut you off for this one yet.
Yep, I was actually going to kind of wrap that in. I noticed we had a lot of questions that have come in about standards, policies, where can I find information on, what standards I should be following, as well as questions about the organizations that we mentioned. So I just wanted to kind of tie that in there to really, Joint Commission standards. CMS has issued a lot of standards recently surrounding medication management. Those are really going to be your gold standard. That's what everyone's going to want to follow because that relates to your billing and your accreditation, right? And so they kind of set the standard, but really those policies are going to differ by state. A lot of that is set by state boards, by state nursing boards, pharmacy boards, where you'll have a lot of variation across states.
Thank you both for your input there, and I think it's just so fascinating to hear when you're talking about bringing the time frame down from something like 12 hours to 30 minutes or an hour. So thanks for talking us through that. We've had several more questions come in, and we'll try to get through at least a few more before the top of the hour. The next audience member was wanting to know, they said that pharmacists are so involved with COVID-19 vaccine efforts right now. Any thoughts on getting them on board with creating a diversion committee?
I can start that one. So it's definitely it's been a it's been a push. I think there are definitely some facilities that pharmacy services just really have not gained a lot of traction as far as within C-suite and admin. Other ones that are more progressive, which I like seeing. We pretty much at this point, COVID was actually our door or our way into working more with different, with nursing, with admin, with clinical physicians. We really were able to step up and show them what we could provide. So I think, at least for us, we needed more pharmacy presence on more committees, more discussions occurring. And once we could put ourselves at the table, we were able to, really start explaining why it's important to us, why it's important to a facility, and why we really need to be at that table as we discuss all these problems.
Thank you so much. And we'll go ahead and try to get to a few more questions before the top of the hour today. So looking through all the audience questions that are coming in, there's a question that came through about whether nurses should correct their own discrepancies, and I'm probably pronouncing this wrong, but in a Pyxis or Pyxis system.
So at least at my facility, we've looked at it, if you are the person that created the discrepancy, that's the one that we want to fix it. We do require a witness to be there for that, for documentation. We do track that on the back end for any discrepancies that occurred. We are able to pull reports just to see, which resolved discrepancies are out there. 'Cause obviously, we don't want these to go under the radar and pharmacy not know what's going on. But, at the same token, I don't want to put the responsibility of possible diversion onto maybe my technician or to a pharmacist who really had no involvement with true diversion. If it's just inventory discrepancy, it's not a big deal for me to go down and help a nurse fix it. But what if that nurse really is diverting? I don't want my name on the correction for that discrepancy. So we've kind of taken an approach to both of them. If we can get a hold of the person who created the discrepancy originally, that is where where the process starts at.